Thank you very much for this very kind introduction. It's a pleasure for me to speak about Presby LASIK. What can we do? And how can I get the first slide here? Thank you. No, it's okay. Wonderful. Yeah.
Please ensure that the timer is fixed for 8 minutes for all of our speakers.
And where it's going on here? Okay, thank you. The history of corneal presbyopia correction. The PRK and LASIK approaches are the sectoral ablation, concentric central near zone, inferior off-center ablation, and concentric peripheral near zone. Here you can see that more than 20 years, nearly 30 years, we are trying to do presbyopic surgery on the cornea. The approaches for near vision enhancement is a bifocal and multifocal ablation. It was central near with peripheral distant from Louis and Bruce Jackson with the physics machine presbyopic LASIK in 2001, and from Franco Bartoli with the wavefront guided PRK, sometimes denoted as Presby LASIK, done with the cult size Meditech MEL 60. The disadvantages of the bifocal cornea, you have to model the cornea for that was the idea, to model the cornea for presbyopia. You have two pictures at the retina, one for far, one for near. One picture is sharp, the other is blurry, or both are blurry. Loss of contrast, light scattering from transition zone, and you have a long-lasting epithelial healing response. Today, approaches for presbyopia correction is a multifocal IOL, the EDOF, the accommodative IOL, scleral implants, small diameter corneal inlay like camera or Presby lens, monovision multifocal PRK LASIK as Presby Max, central steep area with a supracore, femtosecond intracore procedure, and the aspheric PRK LASIK like laser blended vision. The overview about monovision LASIK is monofocal treatment for one eye, dominant eye for far vision, non-dominant eye for near vision, the best current option at the moment, and it is an aspheric ablation. But for more than 1.5 diopter difference, you can have binocular problems. Here you have the supracore, the Bausch and Lomb Technola central sheep area for near vision for patients more than 40 years of age, near addition from +1 till +2.5 diopters, bilateral procedure, prolonged healing time up till 3 months, non-aspheric ablation, pupil-dependent centration critical. Here you see as European multi-center study, and you can see that is for the near vision it seems to be quite good, but for the far vision that lasts a longer time. The binocular uncorrected distance visual acuity on the left and binocular uncorrected near visual acuity on the right. Overview intracore, the Bausch and Lomb Technolas with the femtosecond laser, mainly done from Luis in Bogota, 5-second 5-ring intrastromal incisions to introduce biomechanical changes, monocular correction of hyperopic eyes, central corneal sleeping, a risk of keratoconus, not recommended in my country, clinical data preliminary. The Presby Max from the Schwind Eye Tech Solutions is a multifocal LASIK approach, bilateral multifocal ablation, It's like a Presby Max hybrid. It is coming with an aspheric ablation, one eye for near, one eye for far looking. Multifocality tries to reach binocular vision for far and near, and they have some difficulties at night driving. The laser blended vision is for patients from 40 till 60, bilateral simultaneous treatment, increase in depth of field, enhance abstractions to monovision. Retreatments are possible, hyperopics with and without astigmatism, and myopics are possible. Treatment range from +4 till -6. Advantages: increased depth of field to enlarge the visual acuity in near and intermediate, increased phakic aberration without subjective side effects. Disadvantages: halo, glare, reduced visual acuity, positive dysphotopsia, no reversibility, enhancement possible but difficult and limited to 1.5 diopter anisometropy. We have two groups, one myopic group, one hyperopic group. You see the myopic from -3.40 pre-spherical equivalent, and 6 months later, -0.17 for the dominant and -0.90 for the non-dominant eye. And in the hyperopic group, in the pre-spherical equivalent, +1.68, ±0.2. After half a year, -0.02 for the dominant eye, or for the non-dominant eye, -0.94. Here you see the age distribution, mainly between 40 and 60. Stability in the myopic group, near no, it's nearly stable after 1 year. And in the hyperopic group, you have it seems to have a regression. Predictability in the myopic group after 6 months, quite stable. And after 6, in the hyperopic group, you get undercorrections more than +3 till +4 diopters. The change in corrected distance visual acuity you can see here for the myopic group in 72%, and we gained lines then in the hyperopic group. And the monocular near visual acuity after 6 months, cumulative for the myopic and hyperopic group for JAGA 2 or better in both groups, the same. The binocular near, in comparison with the binocular distance, uncorrected visual acuity after 6 months in the myopic group, we have JAGA 1 and the visual acuity of 20/20 in 61% for the myopic group, and in the hyperopic group it seems to be better as 74%. Complications is the incorrect flap, decentration, monocular diplopy, dry eye, regression, especially in hyperopic eyes. In summary, with the Presby LASIK, all Presby LASIK approaches are far from being perfect. In comparison, laser blended vision seems to be, at the moment, the procedure with the least amount of side effects. Contrast sensitivity in laser blended vision is not reduced because of an aspheric ablation profile. Intracorneal procedures probably could have better results. Thank you for your kind attention.